Thank you for joining today's pre-recorded webinar from the Kentucky Regional Extension Center. Today we are going to discuss the Quality Payment Program 2025 CMS Physician Fee Schedule and Quality Payment Program Final Rule. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. My name is Jessica Elliott, and I am one of the Quality Improvement Advisors here at the Kentucky Regional Extension Center. We also have a host of other experts that are a part of the Kentucky REC and a part of our quality and value team that are here to help our practices and organizations throughout the state optimize their performance in payer programs such as the Quality Payment Program that we are getting ready to discuss. Here at the Kentucky Regional Extension Center, we have provided support for over 5,000 clinicians here in the state. We have actually helped administer over $40 million in grant funds to healthcare organizations around healthcare quality improvement, EHR optimization, HIPAA, privacy, and security as well. So we like to partner with you not just for our fee-for-service opportunities, but we also do a lot of extensive grant work around several different chronic conditions and overall healthcare and EHR optimization avenues to be able to really enhance the care that we all want to provide to our patients here in the state. Some additional services that we provide at the Kentucky Regional Extension Center do include quality improvement support, and particularly that transition to value-based payment, and specifically quality payment program support. We also offer services in the hospital realm as well around quality improvement, promoting interoperability. Now, for our conversation today, I'm going to review some of CMS's finalized programmatic updates as the part of that physician fee schedule that was finalized earlier in 2024. We're going to be talking about some of those changes to traditional MIPS and MVPs, as well as advanced alternative payment models in the Medicare Shared Savings Program. And then we are also going to talk about some of the impacts and implications of this new finalized rule. So in case you are interested in this citation and the official name of this particular regulation, it is found here on this slide, along with links to CMS resources around this rule and other aspects of the rule. Our webinar today is only going to cover the quality payment program portion of the final rule, and we'll also touch on the Medicare Shared Savings Program. That is technically sits outside of the QPP section of the PFS. So if you want more details specifically on some of the changes like around telehealth, MDPP, behavioral health, those would be found in the PFS section of the rule. So just a quick overview of the quality payment program and the participation tracks. We are currently in this traditional MIPS phase. We have, and this is where the program had started in its inception in 2017. Now we have seen the introduction. 2023 was the first year of performance for MIPS value pathways. So we're actually right now finalizing our second year of being able to report in MIPS value pathways. These are more of a streamlined measure set around a specific type of clinician, practice, scope of care, or a patient condition or episode of care. Additionally, we also have the APP, or that's the APM performance pathway. And this is for those clinicians and organizations that are a part of an accountable care organization, an ACO. If you're a part of Medicare Shared Savings, which is one of the most common ones that we see here in the state of Kentucky, typically your organization would report the APP. We also have advanced alternative payment models. If you are a part of a payment model that meets certain defined criteria from CMS, essentially that you are carrying a high enough shared risk as a part of that financial model, and some other criteria, you can be considered an advanced alternative payment model. And if you're a clinician or an organization participating in one of those ACO alternative payment models, then you are actually exempt from the MIPS program itself. You still are a part of the quality payment program and would do your reporting through that advanced APM. Diving into the QPP portion of this final rule, good news, CMS did not make any adjustments to the category weights. We still have quality and cost at 30%, promoting interoperability has maintained 25%, and improvement activities has maintained at 15%. Again, all of this has been previously finalized and mandated by the macro legislation that has enabled the quality payment program. CMS also has not finalized any updates for eligibility to be required to participate in the program. The low volume threshold for participation at that individual or group level is at $90,000 Part B billing, 200 Medicare beneficiaries, and 200 covered professional services. CMS has also maintained the automatic PI reweighting for special status designations. So small practices, HIPSA, ambulatory surgical centers, those designations of clinician types or organizations would receive that automatic reweighting of PI. CMS also did not finalize or extend any new eligible clinician types this year for the program. Payment adjustments. CMS has set the threshold to avoid a negative adjustment at 75 points. This has actually been set now for 2025, 2026, and 2027. CMS looks every 3 years to reevaluate what they will set the threshold to for the program. Again, that is determined by federal legislation for this program. And so just to keep in mind with that 75-point threshold, anything below could receive up to a negative 9% penalty. And then anything above 75.01 to 100 points, you have the opportunity for a potential positive payment adjustment. So remember, performance in 2025, you would actually see any type of positive or negative adjustment on your claims paid out in 2027. So it takes a little bit of time for that to get processed and go through. Within this final rule, CMS did finalize some criteria around data submissions. This is in response to, in recent years, especially with our EUCs, extreme and uncontrollable circumstances, hardship exceptions. CMS has noticed an intake in unintentional submissions. So CMS has qualified some language around that. So looking at the quality performance category, CMS defined a quality submission now as you must submit at least one measure with a numerator and denominator. So that is something to keep in mind, that anything that would submit that numerator or denominator, whether it's an EHR, whether it's a claims measure, that would count as an intentional submission. For improvement activities, one activity must be submitted, and you must attest yes to that activity for that to count as a submission. Promoting interoperability. It would actually include all performance data as well as documentation or indicating any exclusions for any of those performance measures. It also, a submission would have to have attestation statements fully completed. The certification ID, that information would need to be included for an intentional submission, and then also reporting the start and end date for the performance period. Remember that 180 continuous days. CMS also put in some parameters and guardrails around how they are going to calculate scores based on multiple data submissions. So quality and promoting interoperability, these two categories are going to be handled the same way. So if you have an organization, an outside organization, I should say, submit data on your behalf, and you maybe have a couple organizations. You have your EHR that submits data on your behalf, and then you're also part of a QCDR or qualified registry. CMS is going to score each individual submission and assign the highest score for that measure. Submissions within the same organization. So say you have multiple individuals within your organization who are submitting data. Somebody might have submitted your QRDA3 file in November, and then the file is run again and somebody submits it in December. However, there's an error on it. CMS is actually going to only score the most recent submission. So it's very important before a performance year closes for the practice, for the organization to go back and verify that that information is what you intend to update if you're the ones that are self-submitting. All of these changes that we've talked about with data submission actually do go into effect and are retroactive for 2024, so that's something to keep in mind. Now, promoting interoperability is going to be a little different. CMS is actually going to score each and every data submission, regardless of whether it's an internal or external submission, and it's going to assign the highest score possible to that particular category. Now, to dive into the quality category itself. CMS has finalized data completeness to be held at 75% through 2028. So we have several more years of maintaining that data completeness. We do anticipate in subsequent years that data completeness requirement would increase. As far as expanded measures for 2025, CMS has finalized 195 clinical quality measures that are available through the program, either through your EHR via ECQMs, through your qualified registry or QCDR measures, through administrative claims. CMS has added 7 new quality measures and removed 10 overall quality measures from the program. We saw 66 measures with substantive changes in this final rule. As always, we highly recommend that you review any of your commonly reported measures and identify if there are any substantive changes that need to happen to your reporting or to your clinical workflows. CMS did make some changes to an administrative claims measure. It is the risk standardized acute cardiovascular related hospital admission rates for patients with heart failure. This change that they are making is retroactive to calendar year 23. And this change is simply some language around how that measure is attributed. Originally, it was finalized that it would have be calculated both at that group level as well as at that individual clinician level. However, that is inaccurate. This measure is not eligible as an administrative claims measure at that individual clinician level. So they did clarify that language in this rule. CMS has also created some new specialty measure sets. They have pulled apart the optometry measure set, and they've created 2 separate ones for optometry and then ophthalmology. CMS has also revised their policy on topped-out benchmarks. A few years ago, they put in a 7-point measure cap on topped-out measures. CMS has actually revised that, and they realized that that actually does have some penalty for specialty practices who do have a limited measure choice. So at CMS's discretion, they are going to look at those measures that do have that 7-point cap, and they will make that decision and will publish that through the QPP portal and through the QPP or cms.qpp.gov website for any measures that would be allowed to have that full measure scoring all the way up through to 10 points. And finally, just some kind of key takeaways from reading through this regulation. CMS continues to really promote clinical quality data registries as well as qualified registries for reporting. Those measures are continuing to grow as well, and so there's more expanded choice in that. So that's something to consider with our EHRs. We've also seen a trend in more patient-reported outcome measures. So pro-PM measures are something that we are really seeing from our vendors to start to adopt and for CMS to really promote as well. And those can be considered a clinical quality measure and one of your 6 that are required to submit for the quality category under traditional MIPS. On to the promoting interoperability performance category. So CMS has not made any adjustments to any of the scoring criteria, the measures themselves, the performance measures, or the reweighting policies for this category. Really, overall, not a lot of changes for the promoting interoperability category in 2025. There are some things that I do want to make sure that we call to your attention. So back earlier in 2024, CMS actually released an information blocking final rule completely outside of the quality payment program, but I think it's important for us to make sure that it is on everyone's radar. This disincentives final rule impacts the quality payment program inasmuch as if there is a MIPS eligible clinician who is found to be information blocking by the OIG, they will actually go back and change your classification as an eligible clinician to no longer being a meaningful user of promoting interoperability. And they would then reassign whatever score you had earned to a 0. And that applies just to that year that you were found to be information blocking during that performance period. So the implications of that can be that it could impact a potential payment adjustment year. Losing 25% of your total MIPS score would typically bring a clinician down below that 75-point threshold to avoid penalties. Now, safer guides. The ONC, the Office of the National Coordinator, does oversee the safer guide process. They are actually currently updating the existing guides that we have. So something to keep on the radar is that these guides could be updated in 2025. You are welcome to use the 2024 version or the 2025 version for performance year 2025. However, we do anticipate in 2026, once these new guides are already up in place, that will be the new standard to report for the high priority practices safer guide that is currently required for the program. And then finally, the ONC Health IT certification criteria. There are some different aspects that are required to be a part of that CERT build. And so CMS is has required starting on January 1st of this current year that decision support interventions or DNS and other technical updates be in place. Those technical updates would have until 2026. One other reminder, this was actually previously finalized, but I think it's really important that everyone should know that public health reporting, that particular performance measure, you must be live by 25. So this year we have to be connected to those public health reporting registries. We can no longer be in that testing and validation. If you have previously participated in the program and you have attested to option 1, you would now need to report into option 2 for this. So if you are having any issues with public health reporting or connecting to those registries, please feel free to reach out to us. We are happy to help connect you and to help you with that process. Now to improvement activities. There were actually a lot of shakeups with the improvement activity performance category this year. We actually saw CMS eliminate the weighting. Previously, we had highly weighted activities that were worth 20 points and medium weighted activities that were worth 10 points. And so CMS has actually done away with that weighting and they've made it a lot more streamlined. If you are part of a MIPS value pathway, or if you have a special status designation like you're a small practice, you only have to report one activity. If you are participating in traditional MIPS, you would report 2 activities unless you have that special designation. Now, CMS did also add some new activities. They have included an activity around lung cancer screening uptake and also participating in Save a Million Hearts. They have modified one activity, vaccine achievement for practice staff, and they have removed 4 activities. One in particular I do want to call your attention to. It's that provide 24/7 access to MIPS-CCs or groups who have real-time access to patients' medical records. This is a very commonly reported improvement activity for a lot of practices and organizations here in the state. So please be advised that this activity will no longer be available for 2025. One of the things that we have as far as a key takeaway is just an impression from this rule. I think we're going to continue to start seeing more measures removed from the program, more measures being removed and less opportunity. So they're going to really streamline, I think, over the next few years, the improvement activity category, and perhaps even maybe a little bit less of an emphasis on the importance of this category. Now for cost. We did see 6 new episode-based cost measures added. We'll talk about those here on a subsequent slide. We did see some modification around 2 different measures, just some language clarification and renaming. And CMS did not propose or finalize any measures for removal from the inventory. Now, CMS did do an overhaul of the cost performance category scoring methodology. And this methodology is actually, I think it's going to be beneficial for a lot of clinicians out there in the community. CMS recognized that their current methodology was really hindering those practices, those clinicians who are being scored on cost measures if they were close to the national average. And so it was really skewing the results. So they are actually changing the methodology overall for this particular category. They're basing it actually on standard deviation from the mean of performance. And so it's actually going to be, if you are, around, if you're really close to that average, if maybe your costs are just slightly less, you're going to get closer to 7 points now, whereas opposed to previous scoring methodology, you might have only received maybe 3 or 4 points. So this could be particularly impactful for this category and really for your total final MIPS score if you are kind of already in line with the national average or higher. Now, I will say that if you already have like really low performance, like in 2s and 3s, you are probably going to stay a little bit lower on that scale. It's not going to have as much of an impact on those measures that are lower scoring. CMS did finalize some more clear guidance around how they are going to consider and remove certain cost measures. And they also are going to try to be more consistent in how they evaluate measures for future removal. Finally, some of the things that I think is just I just really want us to just touch on is how we really need to keep an eye on how this new scoring is really going to impact overall performance. I think this is a good change overall for the benchmark methodology. And I'll definitely be interested to see, and I think all of us here at the REC will be interested to see what that looks like. Now, as promised, here are some of the additional cost performance category measures that have been added to the program. So we will actually now have a total of 35 measures for the entire program. We were 29 last year in 2024 and now up to 35. So those are going to range from chronic kidney disease and end-stage renal disease and kidney transplant management, prostate cancer, rheumatoid arthritis, all the way to respiratory infection hospitalization. So this is that simple pneumonia measure that was removed a couple years ago and has been retooled to be a little bit more inclusive and just outside of just the scope of pneumonia. They also made a couple modifications. They changed the name of a couple measures. One focused on cataract removal and ocular lens or intraocular lens implantation, and then inpatient PCI. Now, to briefly touch on MIPS value pathways, CMS has in previous rulings discussed a potential traditional MIPS sunset date of looking at 2028, 2029. In the proposed rule earlier in 2024, CMS suggested and were seeking comment on doing a sunset date of traditional MIPS in 2029. And by sunset date, what I mean is that the current program where you submit 6 quality measures and that you can kind of pick and choose any of the measures from the entire smorgasbord of 195 measures to report for the program, and really kind of trying to sunset that and make this a more streamlined, focused program on the type of care that you as a clinician provide or the type of patients that you see or episodes of care that are being delivered. And so what that means then is you would either, if traditional MIPS completely sunsets, then as an organization or as an individual clinician, depending on how you submit, you would need to submit through MIPS value pathways. And that's, again, that streamlined structure of a set of 4 clinical quality measures that are highly aligned with a particular clinician type or episode or patient diagnosis or chronic condition. Your alternative to that would then be to participate in the APM performance pathway or the APM track of the program. And this would require being a part of an accountable care organization or adopting an alternative payment model strategy and contractual relationship with CMS to balance that quality and cost that really CMS uses to define value. And so that's really where we're at this turning point. And so CMS has not finalized the sunset of traditional MIPS just yet, but again, forecasting looking at 2029. So hopefully in the 2026 proposed rule, later in the year here, we should get a little bit more direction on what CMS is thinking for that sunset date. Now, to updates to the MIPS value pathways track of the program. CMS did make modifications to all 16 MVPs. They may have changed around some different measures and things like that for those MVPs. So definitely take a look at that if you are participating or interested in participating in an MVP within your organization or as a clinician, please look at those measures that are a part of that. CMS also did some updates around the registration process and scoring policies for population health measures. And specifically what they have done is originally you would elect whenever you sign up to be a part of an MVP that you elect which population health measure you would like to be scored on, because again, that's part of that foundational measure set of PI and population health. And so there are 2 measures. CMS has decided that they are actually going to calculate both measures for your practice or as an individual clinician to see which one you score higher on. CMS found that there was some gaming in the system, and with the 2023 submission year, potential gaming, I should say, that if you just elected one that you knew that you wouldn't get scored on, then you wouldn't have to worry about being scored on a population health measure. And so CMS wants to remove that potential outcome and select your population health measure for you, and again, score you on the highest one. CMS again continues to align any changes with the cost, quality, improvement activities, PI activities to align with the MVP program as well. subgroups, CMS did clarify a little bit around the promoting interoperability category. Subgroups will submit their PI under their affiliate group. So that larger overall organization, it'll be at that group level and not at that individual subgroup level. Now, we also saw the finalization of 6 new MVPs. The complete ophthalmologic care, dermatological care, gastroenterology, optimal care with patients for urological conditions, pulmonology care, and surgical care. So we are up to a considerable number of MVPs that are available. CMS also indicated in this rule that they feel that there's about 80% of specialties out there, specialty types of clinicians, that are now covered by an MVP. And so in both the proposed rule and this final rule, CMS had a lot of dialogue around the future plans for this program and really how to assist clinicians and EHRs and those third-party vendors as you transition from traditional MIPS over to MVPs. So they are looking at some different special statuses, current flexibilities, reweighting opportunities, and maybe even how to, if you're interested in participating in an MVP and you're a small practice, is there any flexibility that can be afforded, especially if you're a small practice and you have multiple specialties represented. So I think we'll see some more information coming in the next year or so, that because we have 2 years under our belt with MVP reporting. I think for CMS, they're going to have more experience with this, and I think we're going to start to see more clarification and probably some more guardrails around this program. Now, we're going to transition over to the APP track, or the Advanced Alternative Payment Model track, as well as discuss some changes with. Let's first talk about advanced alternative payment models and updates to this track of the quality payment program. So one of the changes that we saw in the 2025 PFS related to advanced alternative payment models relates to the qualifying participant determination. And so originally the lump sum bonus payment that has been paid out as an incentive for providers and organizations to participate in advanced alternative payment models, that has been slowly transitioning and phasing out. Congress has intervened a couple different times, including in 2024 for the Consolidated Appropriations Act that was ratified in early 2024. This actually reversed the complete removal of that lump sum payment. So specifically in 2024, it is a 1.88% partial lump sum bonus payment that has been added back for a qualifying participant. Now, I will say that the macro legislation again indicates that 2025 there is no QP lump sum payment money that's been allotted. Again, that would need to be through another congressional act, through something like the Consolidated Appropriations Act. We are keeping an eye on Congress to see if any additional legislation gets passed that does impact qualifying participants and providing any sort of additional funds for that lump sum payment. However, in 2024, and also now taking effect into 2025, is that PFS conversion factor. So for qualifying participants in an APM, and again, this goes back into 2024 as well, CMS is going to take a 0.75% conversion factor and apply that adjustment to all covered professional services. Now, if you're a non-QP and an APM, you would receive a 0.25% adjustment. So a little bit more favorable of a conversion factor than if you were not a participant in an advanced alternative payment model. Additionally, some changes that were a part of that 2024 CAA that CMS did finalize in this rule go back to the QP determination thresholds for 2024. And so Congress ended up reversing the progression to 75% of payments and 50% of patient count for 2024 determination of QP status. And so you can see on the slide here that for 2024, to be determined as a full qualifying participant in an APM, you have to have 50% of your payments or 35 of your patients tied to that particular APM model. And then for a partial QP, that threshold is at 40 payments or at 25% of patients. Now, again, for 2025, unless Congress intervenes, that QP status volume will actually increase. So you would, in order to achieve QP status, you would need to have 75% of your patients or your payments tied to that APM model, or you can meet it by that 50% patient count of having at least 50% of your patients tied to that APM model. So again, lots to take a look at with this to see if there are any changes in early 2025. However, at this point in time, we do not see that. If there are changes, those would be retroactive, and we would actually see those occur with the 2026 PFS rule. Now to talk about the APM performance pathway. So there have been a couple updates to this pathway in the 2025 final rule. CMS is actually expanding the APP measure set. They have created the APP Plus measure set. So it takes the core measure set that you see on the left-hand side of the screen, and it adds these additional measures on the right-hand side highlighted in blue. Now they're going to do a gradual phase-in for this APP Plus measure set. Something to also keep in mind is this measure set is only going to be required for those ACOs that are already in or participating in Medicare shared savings. So any of those tracks for MSSP, this would be the measure set that is required for reporting. And so CMS is expanding this measure set to really align with that universal foundation measures that they are trying to align across all of their CMS programs to have that standard core set. So we're going to see breast cancer screening finalized to go into effect for 25 for this measure set. CMS did make a change, and they have pushed colorectal cancer screening to 2026, along with that multiple chronic condition administrative claims measure. In 2027, there will be a measure on substance use disorder treatment that will take effect. And then either in 2028 or the year after an ECQM becomes available, the two measures screening for social drivers of health and then adult immunization status will take into effect. And so again, this is all to achieve that universal measure set alignment. And this is again applicable for those participants in a MIPS APM and required for those participating in a Medicare shared savings program to report that APP Plus. Just as a friendly reminder as well, web interface has sunset. 2024 is the last reporting year for web interface as an option for ACOs to report their quality performance to CMS. So these measures are transitioning over to ECQMs, MIPS CQMs, or Medicare CQMs, and that would be the reporting pathway in the future, whether you're reporting the core measure set or that expanded APP Plus measure set. Now, digging into the Medicare shared savings portion of this final rule, CMS didn't make any changes to the quality performance standard for Medicare shared savings ACOs to receive that max shared savings rate. So there's still that bonus that's in place if you do submit via ECQMs. You have to hit the 10th percentile on at least one measure out of that APP Plus measure set. And you have to have the 40th percentile on at least one measure from the APP Plus set as that submitting ACO or APM. Or you can have a health equity adjusted score greater than the 40th percentile across all quality performance. So if your final quality score is greater than the 40th percentile across all eligible clinicians, not just those in an ACO, but all eligible clinicians, you could meet the shared savings threshold that way. Now, CMS had sent out a request for information around how to make the shared savings program a little bit more financially lucrative. This would apply only to the enhanced track, which is an advanced alternative payment model. So remember, both tracks E and the enhanced track have that advanced alternative payment model designation where you could qualify as a QP and be MIPS exempt. CMS has also extended and finalized an option for APMs or ACOs to have prepaid savings based on previous shared savings. And so what this is, it's similar to those advanced investment payments for new ACOs, but this is for existing ACOs, and it's a payment that's used to be able to expand your care that would go back to benefiting the patient. It would be something that there are very clear parameters around how this money could be used. However, just like with AIPs, it is expected that this money is paid back through future shared savings. Now, some of the changes to ACO eligibility that CMS has made for the first time ever. Typically with Medicare shared savings, you have to maintain 5,000 assigned beneficiaries throughout the duration of your time in the program, through all of the years within your agreement period. You're not allowed to drop below that 5,000. CMS has changed that, and you only have to meet that 5,000 at that initial time of agreement and whenever you renew. So you can drop down, below 5,000 in your second year if it's not a renewal period or you're not escalating in another track and signing a new agreement. And then finally, CMS has allowed for a health equity adjustment benchmark. They've made some updates to this. They're actually doing a combo of 3 different types of adjustments. So it's going to look at that positive regional adjustment factor. It's going to look at any prior shared savings. So if you have in the past had shared savings, that's going to help be a little bit of a bonus. And then also that health equity. And so again, HEBA is that percent of Medicare Part D patients in low income subsidy, or those Part D beneficiaries who are dual eligible for both Medicare and Medicaid. And so by updating this health equity benchmark, it bolsters your benchmark a little bit more. CMS is trying to do this to course correct, because as you achieve shared savings, as you lower your expenditures on your patients, your benchmark also lowers. And so at some point that belt gets so narrow to be able to achieve shared savings, you can have an opportunity to bump your benchmark back up a little bit, depending on your regional adjustment and your history of shared savings, and then your ratio of vulnerable population of patients. So CMS has created several pathways within the quality payment program to really meet what they consider the definition of value-based care. And all of this is really to align with their Healthy People 2030 initiative, in that they want to have all traditional Medicare beneficiaries in some type of an accountable care payment model or arrangement by 2030. And so there's a couple different ways that we can find ourselves meeting and achieving that aim. So the first is through MIPS value pathways. CMS has really spent a lot of time and energy trying to align the quality performance to more directly correlate with the type of care that's being provided clinically. So there's more, what CMS determines is more meaningful measurement of performance. And again, CMS is continuing to grow these pathways. And they mentioned about 80% of clinicians are represented. That still leaves 20% really trying to figure out how they would function in MIPS value pathways. And then also too, for larger organizations, that's a bit of a of a concern is how many MIPS value pathways you would need to report to cover the types of clinicians that are within your organization. So multi-specialty reporting for MVPs is definitely a factor to really consider moving further down this path in future performance years. CMS again has not finalized a sunset date for traditional MIPS, but every indication is that they are moving in that trajectory and looking at potentially 2029. So really that leaves us with a couple different pathways. You're either going to be a part of that advanced alternative payment model track, right? That you are in a model that has a higher rate of risk as well as shared savings, and or even full capitation. Or you could be a part of the MIPS track, which is going to be either participating in the APM performance pathway, or if you are participating in an MVP. So here at the REC, we want to help all of our practices, all of our organizations here in the state of Kentucky thrive. The higher quality, the better care, the better outcomes that you have at that individual level help all of us, help all of our family, help all of our loved ones. So we are here to help guide you through improving your clinical quality performance so that you can be more financially viable in these types of payment arrangements. We also do education on specific payment models. If you're interested in participating in and making that connectivity with it, we also can help you with that model selection and identification. And then also when you're already a part of an ACO, we work with several organizations on helping to monitor their individual clinical quality performance in order to really be able to be that strong contributor to their overall ACO. So lots of different opportunities for us to help prepare you either for the MIPS value pathway in selecting and really setting up your operations to be successful in those pathways, or through that transition of being a part of an advanced alternative payment model. Now, to go through some of our impacts of the PFS and Quality Payment Program final rule in 2025. So these are in no certain order, but I think I just want to go over a couple of these highlights just to keep fresh in our minds. CMS did not finalize, nor were any ECQMs proposed for 2025. So that's something to consider. A lot of us use ECQMs for our reporting for the program. So again, we want to keep our eyes set to that to see what else comes down the pike. Data completeness has been finalized at 75% through performance year 2028. CMS is removing that 24/7 access to medical records for improvement activities. So again, something to consider. Are you currently reporting that for 2024? That is going away when you do your attestation for 2025. So best to go ahead and select that now. Safer guides, those are getting updated in 2025. You can have the option of reporting the 24 or 25 version. We do anticipate that that next version will be required in performance year 2026. Some other changes to improvement activities, CMS removed the different weights, and they've really streamlined the number of activities. If you're in traditional MIPS, you're going to do 2. If you're in MVPs or if you have a special status, you're only going to have to report 1 activity. CMS is expanding some requirements around the Medicare Shared Savings Program by requiring the reporting of the APP Plus measure set for all Medicare Shared Savings ACOs, regardless of track. CMS has also, for the entire MIPS program, they are maintaining that performance threshold at 75 points. And again, that is being maintained through 25, 26, and 27. CMS has revised their topped-out measure benchmark policy. This is going to apply to certain measures that are found in specialty measure sets. CMS will make that determination if that benchmark does need to be adjusted so that they can, you will no longer have that 7-point cap, that those reporting those measures could receive up to 10 points. CMS has finalized 6 new MVPs for 2025. That brings our total to 21 MVPs that are available. CMS has expanded our cost measures. We now have 35 measures available, and they have updated their benchmarking and scoring policy for this category. So hopefully we can see some more advantageous scoring around our cost performance measures once we get feedback for 2024, because again, this is a retroactive change. Now, some action items to take away with you. Again, remember that public health registry reporting requirement is in effect now in 2025. You have to be live on your public health registries that you are attesting to for that objective within the PI category. If you do meet exclusion criteria, then there are those exclusions available, so just keep that in mind. If you are having your vendor submit data on your behalf, right, through like an API to the QPP portal, that EHR vendor will have to be certified as a registry. So that's something to consider whenever you're reaching out to your vendor. If you do know that they already submit for you, making sure that they have that registry designation. We want to work on your improvement activity alignment, making sure that any new activities you select for 2025 are relevant and appropriate. And if any of your activities have been adjusted or changed in previous years, that you are keeping the appropriate documentation for that whenever you attest to it. And we also recommend that you review the new cost measures that CMS has finalized, see if any of those are applicable to the scope of work or the practice, your practice billing, to see if you would qualify for scoring for those measures and make appropriate adjustments as necessary. So now here at the Kentucky Regional Extension Center, there's a lot of different things that we can help you do. We can work with you on identifying your measures that are important to your organization, looking at alignment across different payer programs to see what measures you can work on to really get the biggest bang for your buck, so to speak. We all realize there's so many different irons in the fire and so many different regulatory programs. Trying to work to find ways to maintain that alignment and to keep your entire team rowing in the same direction and not feel so scattered is really important. And so we're here to help you with that. We are also here to help you with gap analysis, IDing those opportunities for improvement in your clinical quality performance. We can also assist you with clinical workflow mapping, making sure that the processes that you have in place are accurately capturing data and accurately meeting the intent behind the measure. We can also work with you on EHR reporting optimization, making sure that your reports are pulling correctly, helping you validate your numerators and denominators, and also really kind of helping you identify like the best strategy for your measure performance. We also do targeted measure education around all of the performance categories: quality, cost, and promoting interoperability. So we can help you dive into any of those measures and within any of those performance categories, and to really be able to get you some focused interventions to be able to improve performance. Again, I mentioned earlier, we do provide data validation support offerings. Data in, data out is only as good as the data that you put into your EHR. And so, making sure that what you put in and how it's captured and then how you're able to extract it is accurate and reliable, so that you can meet current data completeness requirements as well as future data completeness requirements. And also, really, whenever you're looking at improving clinical quality performance, you have to know, where you've been, and accurately know where you've been in order to set goals and get a shape of an idea of where you want to be. And then finally, we do provide some performance feedback analysis from CMS's feedback reports from the quality payment program. So we work with you looking at a deep dive into your clinical quality measures. We also help you look into your performance feedback, those patient level detail reports of your cost measures that you have been scored on in previous submission years. So that's something that you can take then and help identify those areas of greatest need and build interventions around to improve future performance for those measures. Now, as you can tell with this program, there are a lot of moving parts and pieces. And we know that you have so many different areas and different that you're trying to navigate and fires that you need to put out. We want to help you navigate the quality payment program, navigate quality improvement in general within your organization or within your practice. You know, what you do here in the state of Kentucky impacts us all. And so if you have questions, if you would be interested in support, exploring some of the different offerings that we have here at the Kentucky REC, please don't ever hesitate to reach out. Call us directly at 859-323-3090. You can reach out to us on our website at kentukyrec.com. We post previous webinars, we post information sheets, we have blog posts that release recent announcements from CMS that are pertinent and relevant to the scope of work. And so stay tuned with us to learn more information. And you can also email us directly at kyrec@uky.edu. Thank you so much for joining us.